I'm Dr. Dan Cox, a professor of counseling psychology at the University of British Columbia, and welcome to Psychotherapy and Applied Psychology, where we explore practical insights with leading experts. Today, I am thrilled to welcome back Dr. Stephanie Budge, a world authority on trans mental health. In our conversation today, we discuss minority stress, the role of psychoeducation, internalized transphobia, the companionship model of letter writing, challenges to doing trans-related research, and much more. And please feel free to leave a comment below. And if you enjoy this conversation, it would be very much appreciated if you hit the like button and subscribe to the channel. This episode starts with Dr. Budge talking about how to attend to minority-related stress with trans clients. Let's jump in. So for the intervention side of it, you have the transgender affirmative therapy, and then you also added on this building awareness of minority-related stress component as well. Could you tell us a bit about that?
Yeah, so we all of the clients who were randomized into the BAMS group, we had a tool that was called the minority stress tool that we provided to them, where there was an entire psychoeducation component before therapy even started, where we talked about here's what minority stress is. We provided definitions of it. We talked about examples of how that happened in therapy or just happens in general for people. And then we asked them to give some examples of things that they would like to talk about in therapy. And so based on that, we were trying to help provide some psychoeducation on the language and naming that minority stress is something that exists. But there's also even more data now than there was at the time when we were getting this ready, that externalizing the problem is really beneficial to being able to help reduce distress for trans people. Like, oh, there's an actual label for why I'm experiencing this. I had no idea. And that's actually what people would say when we were going through this tool. They're like, why have I never heard this before? I'm like, it's game changing. It's life changing to hear that there is an actual concept to describe what I've been experiencing. So that happened before psychotherapy even started. So we did the psychoeducation session, and then they started psychotherapy. And then the supervision was focused on using this minority stress framework. And then before every session, we had clients, fill out measures like they typically do in psychotherapy research. But we also, for the minority stress group, we said list up to 3 minority stress events that happened over the last week. And let us, and as a way of thinking about if you want to talk about them or not. But we did tell people you don't have to talk about minority stress in the therapy. You don't have to talk about these 3 things that you're listing out. It's not a requirement. You get to talk about what you want to talk about in therapy. But I think the main difference was that they got a psychoeducation. They were thinking about some of these factors as they were going into each session, and the therapists were trained specifically in the framework, both before and then during the intervention.
So, what is minority stress?
Yeah, good question. So there are a couple of scholars who kind of talked about this term. So Virginia Brooks in the 1980s, and then Ilan Meyer in the 1990s and then thousands, specifically started talking about minority stress related to lesbian, gay, and bisexual people. And the way that they had talked about it was that there are reasons why lesbian, gay, bisexual people experience higher rates of distress and depression, anxiety, other things. And the 2 primary factors that they theorized that were involved in that were distal stress, which are kind of these external things that happen to you related to your, in this instance, sexual identity. So things like discrimination, harassment, bullying, rejection, those kinds of things are distal or external stressors that happen that are directly related to then an increase in depression, anxiety, other types of distress. And that there are these proximal or internal stressors that happen too, that are internal to the person, that are also related to distress. So those internal processes are things like expectations that discrimination might happen, or expectations of rejection, concealing your identity, internalizing stigma as a way of believing that there is something internally wrong with you and inherently shameful about you. And that there's a direct relationship from those things also to increased distress. In 2012, Michael Hendricks and Ryland Testa extended that framework to focus on trans and non-binary people. And then this kind of in the last decade, there's been a kind of an explosion of research that has been testing this framework, because I kind of simplified it, but there are also lots of paths that focus on coping, for example, and resilience and stress factors and community and different kinds of things that are also in the model that are that scientists are testing.
So what you were saying, that the clients, just by learning about this, just sort of psychoeducation about this, they sort of had some aha moments.
Mm-hmm. Yes. And it's interesting, because then if you're thinking about the mechanism of change for psychotherapy, you're like, is it the psychoeducation that happened prior to the therapy even starting? Or was it that in addition to the psychotherapy? Was it the psychotherapy? Because interestingly enough, like both groups improved, but there was more improvement in the BAMS group, specifically related to internalized transphobia.
That was a question that I was going to ask, sort of like what you thought were like the minority stressors that were most relevant, important.
Mm-hmm. Yeah. So I think that internalized transphobia one was the one that stood out to me the most, because that one, I think, if you're really, when I think about what we have control over as therapists, we don't have any control over the distal stress that people experience, right? If people are experiencing rejection, harassment, bullying, victimization, the only control we have in the one-on-one therapy room, this is individual therapy, is to talk with them about that experience and empathize with them, perhaps provide them with some coping skills related to that. But I do think we actually, in psychotherapy, we have more of that ability to focus on that internalized stigma, which is really what a lot of the supervision was about in that group. So it makes sense to me that was an outcome, that was a targeted outcome that we were testing, and that demonstrated bigger gains for that group.
So what is internalized transphobia?
It's that I was kind of defining it a little bit ago, but it's that taking in those external messages that you're getting and believing them, basically, that there's something wrong with me. My identity isn't real. Am I really trans? Trans people are bad. It's basically all these messages that are happening from an external perspective. You are taking them in and then you believe them and internalize them as being true.
So stuff that like the I shouldn't be, or I should be, or it's not okay for me to, or I am wrong about that around their gender identity.
Mm-hmm. Exactly.
Okay. So when you're like, okay, so the folks in the BAMS, the intervention condition, they got this training at the outset, and then in the training, but then weekly, I believe, they were sort of prompted to come up to, I'd say, like, were there any of these minority stressors that happened to you over the last week? And if so, do you want to talk about them in therapy? Right? Is that about right?
Yeah, well, it's mainly they could list out up to 3 minority stressors that they experienced over the week, and the therapist would prompt for that at the beginning of therapy. Is that something you want to talk about today or not? So that was the process. I will say, and I don't know if this is, maybe interrupting you from your question, but the clients did not like filling out the weekly minority stressors prior to therapy. And that was something we wrote up a paper about, the minority stress tool. Mm-hmm. And this was feedback that we included in that paper, where we said they really liked the tool, but they did not like filling out the weekly minority stress events.
I don't understand what you mean. They like the tool, but not filling out. Like, you mean the tool? You mean the thing at the outset that they did?
Mm-hmm,
Oh,
exactly.
okay.
Yep. They found out of all of the pieces that were related to minority stress for them, they said they really, really appreciated the tool. We got a lot of positive feedback about the tool and being able to have something tangible that they could take with them, that they used that information outside of therapy when therapy had terminated, but that they found it annoying to list out what their minority stress events were from the previous week.
Huh. So what's your takeaway from that?
You know, I got it. I feel like that was feedback that made sense to me. I think, when you're designing psychotherapy, when you're designing any research, you know that there are going to be components that you won't do again. And I wouldn't do that part again based on the feedback. I don't actually think that that was helpful to them. It didn't seem like, I think the goal in mind was to prompt people so that they were thinking about it prior to going into therapy, and we were really priming people. But it makes sense that, if it's important, it's going to come up anyway. And also perhaps the techniques that are being used around helping to reduce internalized stigma and helping with coping skills related to this kind of external stressors that are happening, that can all happen regardless of priming people for the minority stress events that they had over the week. I also just think it was distressing to clients. I think that we were priming them to describe something that was highly distressing, and people didn't like that. And there are perhaps other ways to do that.
But so, like, were they filling it out like at home or wherever they were before they came in? Were they filling it out in the waiting room?
They filled it out in the waiting room.
Oh, that's interesting. So like where I've worked with where we used like outcome assessment, like the outcome questionnaire 45 and stuff like that, and people fill it out in the waiting room. And I always felt like my experience with clients was that as long as you like brought it into the session, even if only briefly, like they didn't mind. They're sitting in the waiting room anyway. So it takes 3 minutes, once you do it a few times. So that's interesting then that they didn't like it. You know what I mean?
Right. Well, they filled out the OQ45 at the same time as well. And they did not say that we did not get the same feedback about the OQ45.
Really?
But they did not like filling out the working alliance inventory. So, we got a lot of feedback about the measures that we used in the trial. This was, I would say it was a pilot study. And so we were really thinking about this from a feasibility perspective, and it gave a lot of information for the next clinical trial that we were going to do. But I think, so people didn't mind filling out the OQ45.
Okay. 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 So, I mean, would you then, because it seemed to me like part of the BAMS intervention was, right, I mean, there's the training, and part of the idea was behind it was like, let's give the opportunity, let's sort of open the door to this conversation. And that was one of the goals for having them fill out their minority stress experiences weekly, as I read it or interpreted it. Would you still try to do that? Like if you were to, like, would you have therapists instead maybe just bring it into the conversation routinely? Like,
yeah, I think it's more the conversation. And actually this did impact, because we did another study that focused on also people being able to talk about oppression and psychotherapy after this on a much larger scale. And we did not do any prompting of any type of oppression-based experience in the survey that they took prior to starting the therapy. And so we did take that feedback into account. And I do think when we were training the therapists in the next clinical trial, it was more around, how are you talking about this? We're going to provide you with, this subsequent one that we did was focused more on radical healing and more specialized interventions for internalized stigma based on the information we'd had in this RCT that we've been talking about. And it seemed like just from getting the feedback that we got from the trial, the clients were less annoyed by the measures and things that they had to fill out ahead of time. And the effects were even stronger in this next trial that we did for improved mental health. So I think part of it is, this is what we always do, right? This is science. You have a hypothesis for how you think things will work. You try it out, you get feedback, and you adjust and you change based on the information that you receive.
So what were some of those interventions for internalized stigma?
The ones that we used in this next trial? Yeah. So Dr. M. Matsuno and Dr. Tanya Israel created an online intervention that focuses on internalized stigma for trans people specifically. So they have it's a 4-module online intervention that they created. And so what we did is we took the 4 online modules that they created from their study, and we adapted them for psychotherapy. And so there are a few different things that people can do. One is the process of externalizing, which we've talked a little bit about already. The second one is kind of some interventions that are focused on self-compassion. So those are things like in the online intervention that the participants would read a scenario where there's a transgender youth, and they would write a letter to that youth to say, like, here are the things that you can here are the things from my own personal path that have worked out, or things that maybe you could anticipate. So it's basically writing a letter to a youth about the kinds of things that can work out in the process of being a transgender person. So it's kind of that process of giving advice to somebody else, and then you read your own letter, and like, how do you internalize that information for your own self? Because I think the idea here is that it's so much easier to have compassion for someone else and to give advice to other people, but it's so much harder to believe that. So these are just a couple of examples. There's also in the online modules, there's a lot of information about like positive psychology and trying to create spaces for joy and resistance. And so that's another component that's included in it. But those were just a few things that we talked about. We really focused on using the radical healing framework that French et al. It's a French there are a bunch of people who are part of this radical healing collective who've created this framework. And we consulted with 2 of the people from the radical healing collective to help guide how we trained the therapists in our next study.
So what is radical healing?
Yeah, it's a good question. It's a really big framework. There's a lot of information in it. I would say the very first article that was written about this in the more recent years. So like I said, it's French et al. It was, I think, Counseling Psychologist is where it was published in 2020. And it's specifically for people of color. And it's interesting because I think for our next clinical trial that we did, it was for trans people of color. And so we were really talking to the developers of this framework around how do we adapt the radical healing framework that we really primarily focused simply on people of color to also include like a gender perspective. And both of the people who we had consulted with do LGBTQ work as well. So they were able to help guide us in thinking about how do we actually think about this framework for Two-Spirit trans non-binary people of color. And there are a few components that are included in the framework, but I would say the things that we focused on the most specifically are things like critical consciousness. So in therapy, how do you actually help clients to be able to become active change agents and to feel a sense of empowerment? So that's like one piece. Strength and resistance is another component. Radical hope is another piece that's included in this framework. And collectivism and community. But the idea behind this radical healing framework is the dialectic, holding a dialectic with clients around saying, it's not just like sitting in the oppression, and it's not just like saying everything's going to be fine, but it's this idea of saying we're going to hold the fact that you experience oppression and talk about the reasons why, while also talking about this concept of kind of radical hope and helping you to hold both at the same time. And so we spent a lot of time trying to figure out how to incorporate these concepts for trans people of color.
Okay. So one of the things that, as you were talking about internalized stigma, that I wanted to ask you about, based on for you having thought about this for years, that like, how do you, or how is it like qualitatively different from like internalized beliefs about other types of things, sort of like other I should, I ought kinds of statements that often show up, obviously, in therapy?
Yeah, I mean, I think that probably the cognitions look the same from my perspective. They probably look the same, but I think that from a cultural perspective, the messaging is different, right? So I think most of that kind of internalization of shame in any way is culturally based, right? I think the flavor of experiencing it because of like marginalization does seem different because of like the power systems that are involved and who gains in those instances and who doesn't, right? So like people who have more power are not going to have that internalized stigma. They're not going to have that. That's not going to impact them at all. And therefore, there are always going to be advantages to them because they don't have to manage that.
Okay. Yeah, I think that makes sense. Sort of this idea of like a lot of those, the beliefs, there's a lot of similarity in terms of shame related beliefs, but that if we think about where they come from and what that looks like, the implications of it in the world, like almost outside of the self, it is different. It is unique.
Right. Because literally anybody can experience like what you're describing as kind of these greater cognitions around like, oh, I shouldn't be like this, or, that can impact any human. But to me, the difference is this will only impact the humans who are stigmatized in those very specific ways. And therefore put them at a differential impact, because we know that those kinds of experiences of internalizing stigma are related to greater mental health impacts and lower quality of life.
So, okay, so if we could take a slight left turn, and because I think that one of the things that folks are going to be interested in, and you've talked about a little bit, is letter writing for transgender, non-binary clients who are considering medical intervention. I was wondering first if you could just sort of give us a very brief sort of lay of the land on what that is, what that looks like.
Yeah, and I'll talk about my experiences all in a US based context. So
Sure,
I can
of course.
talk a little bit about that. But that right now, where I practice, there are these letters called referral letters that basically either medical offices or insurance offices require of a trained mental health or medical provider to say that a two-spirit, trans, and non-binary person has the capacity to provide informed consent for gender-affirming medical care. Now, that's my definition of it based on the World Professional Association for Transgender Health Standards of Care, like the most recent guidelines. However, I think historically, these letters have been used differently and continue to then be used in different ways because of misunderstandings around what the purpose of these letters is for.
So what you said is very narrow, at least how I heard it, which is, um, is this person able to provide informed consent? So is this person of sound mind? I don't know if that's which is I mean, I'm sure there's a lot of nuance in that, but that's a pretty narrow question to ask, right? Right?
Yeah. Well, and I think maybe I think of this in terms of what the capacity is of mental health providers, right? Like we are trained to assess informed consent, and like, can our clients actually provide informed consent? That we do this with every single client who we see at the beginning of any type of assessment or clinical interaction that we have with them, and especially in the beginning when we have our informed consent procedures. But I think how these letters have been used historically have been that there is basically a gatekeeping, that there is a mental health provider or medical provider who says you're really trans or you're not trans, or like you haven't thought about this deeply enough, or you don't understand what this is enough, or you don't have access to the types of resources that you need, and therefore I don't think you're able to engage in this process. So historically, things like if trans people also had additional mental health concerns alongside the gender dysphoria that they were experiencing, that might disqualify them, for example, from receiving gender-affirming medical care. Or like there was something that was called the real life test. And if like the trans person hadn't like lived as their like current gender for a certain amount of time, that they would not be approved to have gender-affirming medical care. So I think in the past, actually, I would say the way that these have been used and thought of have been less related to informed consent, but literally the way that they're talked about right now in terms of the guidelines is that our role and what our capacity is as mental health providers is to see, can this person actually provide informed consent? Do they know how to have these kinds of conversations with their medical provider? Can they consent to these medical procedures when they're having that conversation with their medical provider? Because I can't assess for informed consent for a medical, I'm not a medical provider. If I ask them, when I do ask them questions like, what do you expect the side effects are going to be? Because I think that that's part of an important part of the process that we're supposed to do when we're writing these letters. I do want to know, like, how much does this person actually know? Has their doctor educated them on this? How much information have they engaged in? But I'm not the medical provider. So if they don't know all the side effects, and also, I mean, the other part of this is like, I think of all the medical procedures I've ever had, and like my level of knowledge into the side effects of the things that I've had has been pretty minimal, actually. And so, it's kind of trying to think about, it's important to engage in these conversations, but to what extent what's our expectation for what a patient should know prior to going in and talking to a medical provider versus after?
So I was under a false assumption about basically how you describe these as gatekeeping. That was my understanding of what these were. So this is super helpful for me because I was wrong. And this framework of thinking about just the informed consent piece of it is just, that makes so much more sense to me. And like when you're talking about what I hear you saying, when you're saying like asking them questions about, what do you expect the side effects to be? What I'm hearing you say is that you're assessing for a very basic level of knowledge that would be reasonable for someone to give informed consent to do something, right? Like if I totally agree with what you're saying, but if, it would be reasonable that if you're going in for some sort of serious surgery, that that you'll get information about like what how long you're not going to be able to do what is going to be after the surgery. What's the probability of success? What's the probability of, of dying? What's the, right? Those very foundational things. Cause that, if you don't have that very foundational stuff, then you can't, you don't have, you're not informed. So how could, right. So you want people to have that basic information.
Yeah. I mean, I will say, how do I want to talk about this? this is how I talk about referral letters, and this is how our team talks about referral letters. This is our understanding of the standards of care. I think how they're actually used, in my experience, is more of a gatekeeping way. And I think a lot of people are trained to use it in a gatekeeping way. So I think your understanding is probably more in alignment with how these letters actually often occur rather than the literal interpretation of like what the standards of care ask for. And in fact, in the standards of care, letters aren't required. And it's more that insurance companies often require the letters, or medical providers will require the letters. And so therefore the client will need to get a letter from a mental health provider or somebody who writes these letters. And there are lots of information in the standards of care to say, when you are doing an assessment with someone, when this letter is happening, here are all the things that are important to do, and like talk about fertility, but that's all part of like the informed consent. But they have all sorts of things like you should assess for gender dysphoria. You need to talk about fertility. You need to make sure that you have all the qualifications that you need to be able to write these letters. So I think when we write about this, we write more around, these sessions often feel highly invalidating for a lot of trans clients, that it can feel discriminatory to a lot of trans clients because this is not a procedure that's required for many other medical care pieces. For some there are, there are some components of medical care that do require a psychologist or mental health provider sign off, like transplants and bariatric surgery, things like that. But I think the question for trans people is like, why is this on the same level of that? But in our writing about referral letters, we say, we're not going to comment on whether or not these letters should be written or not in our frameworks. We say, if you are asked to write a letter, here's a framework to use.
And you talk about the companionship model, and that's really what I wanted to get to, was for you to sort of communicate what that's about.
Yeah. So we wrote an article about this companionship model, which includes, we say the acronym VACE. So validating, asking, sharing, and engaging. And basically we provide a way to hopefully help the assessment session just feel more affirming for a client, in a way of saying like, how are you feeling coming in? A lot of times clients are pretty angry that they need to come in. So part of that is like validating those experiences, talking with them about that. And that totally makes sense. Or if they're like, I'm really excited to be here, I can't wait, then validating that. So it's more like kind of assessing where the person's at for how they feel in relation to getting this letter. And then also just we say, like asking them about their own reactions to the letter writing process, that the clinician can share their own feelings about gatekeeping and things like that with clients, but at an appropriate level based on what clients are disclosing. And then also engaging with them in a collaborative way with writing the letter. And especially since clients, if they need to be in the session, we especially say this is such a great moment to give clients resources. And so really, like, if they're paying for the session, especially, most people do have to pay for these sessions, like give them their money's worth, like let's like think about how to connect them to different resources and different things they can get connected to. We offer lots of examples of how to do that in the article.
Yeah, so it's a framework for making the interaction less top down, making it more, frankly, I hesitate to use the word therapeutic because it's not necessarily you're doing psychotherapy, or that's not necessarily your charge, but there are some parts to that in the process, and at the very least destigmatizing and not hurting the person in the process.
Yeah, exactly. Or just like sitting with them in a process. I think regardless of where your orientation is to writing these letters, I think being able to sit with somebody and whatever and how they feel about the process, I think, can be really important.
Yeah. So is there any pushback or any challenges that you want to talk about in relation to your work?
Yeah, I mean, What do I want to say about that? I think, yes. Doing work related to trans people right now is controversial where I live, and across the globe right now. So I think it kind of depends on pushback. In general, actually, I found a lot of support. The university where I work is incredibly supportive. The community is incredibly supportive where I live. So I would say actually the majority of my experiences have been really positive ones, and ones that have been with open arms and support, and reasons why I've been able to do this work, right? Like the places where I've worked have funded the research. And so I think that in general, I would say most of the experiences that I have had have been supportive. I think right now, we have an NIH, a big NIH grant that focuses on social support, and there's some uncertainty about federal funding right now in the US around trans-related research. And so I'm curious to see what's going to happen there. I've also received, things like hate mail to my office, and trying to figure out, like, what do you actually do when that happens, when you get like threatening mail?
What do you do?
Yeah. Well, I found out through this process that you need to report it as stalking at the university. So I had to take pictures of it and send it in to the university. I think anybody who's doing trans-related work at the university is getting support related to, like, what happens if people do reach out, if there are things that happen. And yeah, I mean, I think just part of it is just trying to be prepared for that. And also thinking about, like, the level of impact. Like, I'm making these decisions to do this work, but like my wife, for example, and our kid, like, my wife worries more about this than I do. So I think part of that is kind of that, having that orientation to, like, the decisions that we make and who that impacts in our family. But also, like, thinking about the broader community as well. So there is a lot of there's pushback, and I would say, though, the majority of the experiences that I've had have been incredibly supportive.
Yeah, it's kind of fascinating to think about somebody like yourself who's doing the work that you're doing, and you have this other dimension of challenge that most of us don't have.
Yeah, I mean, it's so interesting because I think of the researchers right now who are doing this work, who are incredibly impacted, are people who are doing, like, vaccine related research, who are doing immigration related research, who are doing climate change related research. Like, there are pockets of us right now who I think are being particularly heightened, and it's incredibly stressful. But I think anybody would say, from the researchers who I work with, would say, we know that science is important, and that being able to engage in the scientific process and being able to trust evidence-based processes is incredibly important. And we want to be able to be a part of that. I also will say, being a cis person who's doing this work, that's also something, like, it doesn't impact me as much as it does the colleagues who are trans.
Right.
So,
right. Interesting.
Yeah.
So one of the things I always like to do is sort of give an opportunity, if there's any resources that you want to provide that here, and then I can link into the show notes as well. I mean, there are a few things that I got. So the app that you talked about, the guidelines in terms of letter writing, I think would be super helpful. But if there's anything else, particularly if there's anything, that you want to send folks to in terms of if they want to learn more about your work.
Yeah, I will send some information. I also think there's something called the Gallup, which I don't remember what exactly that stands for, and I'll send that along. And I think it might be mostly focused in the US, but it's a database of therapists who will write letters without cost in the US. And perhaps it might even be extended from the US. So I'll send that as well.
Thanks so much for watching. And if you found the show useful, please like and subscribe to the channel. I'll see you in the next video where we continue exploring the science of psychotherapy and applied psychology.